All right, welcome back to another episode of Pathagonia. So today we're going to talk about GI neuroendocrine tumors. So let's jump right into it. Neuroendocrine tumors, obviously for neuro, it's referring to containing secretory granules like synaptic vesicles. Endocrine can be referring to the secretion of peptides and amines locally. So neuroendocrine tumors can arise anywhere in the GI tract, and they have a characteristic morphology and protein expression. So for the immunohistochemical markers, note these may also recognize neurons and neuroblastic cells. So for the IHC that we're going to use for neuroendocrine tumors, the classic neuroendocrine entities, synaptophysin and chromogranin, is going to recognize the dense core granules, and then CD56 and neural specific enolase, or NSE, which is less specific, and there's often dot-like perinuclear staining with cytokeratins. A newer and pretty effective IHC is INSM1, which is a new neuroendocrine transcription factor with a nuclear stain. Moving on, you can have a well-differentiated neuroendocrine tumor. In the morphology, you're going to have these uniform round nuclei, as shown down here, with that salt and pepper fine speckled chromatin, granular cytoplasm, and then organoid architecture, or nested cords, gland-like rosettes, or ribbons. For a well-differentiated neuroendocrine tumor, you're going to have no necrosis, and you're going to have variable stroma, and you can see amyloid deposition. So well-differentiated neuroendocrine tumors are also known as carcinoids. And then for the molecular, for a well-differentiated neuroendocrine tumor, it's MEN1, DAX, and ATRX mutations are common, particularly in the pancreas. And these are malignant, but slow-growing indolent progression. And early neuroendocrine tumors have a low risk of metastasis. So somatostatin receptors can detect with DOTA and PET radiographically, or the DOTA scan, and they're graded 1 through 3 based on their Ki67 and mitoses, which we'll go over on the next page. But this kind of nested architecture with these round nuclei, salt and pepper, that's classic for a well-differentiated neuroendocrine tumor. Next up, we got poorly differentiated neuroendocrine carcinomas. So these often arise from non-neuroendocrine tumors and subsequently develop neuroendocrine differentiation with a sheet-like growth, and these are not graded. They are malignant and very metabolically active, so they're rapidly growing. As you would imagine, they would have a very high Ki67 expression, almost 100%. And you can see on normal FDG and PET scans, the molecular for a poorly differentiated neuroendocrine carcinoma is P53 or RB1 and other carcinoma-associated mutations. And then treatment is platinum-containing chemotherapies. So a couple examples of poorly differentiated neuroendocrine carcinomas. You have small cell neuroendocrine carcinoma. So the morphology, you have fusiform nuclei, finely granular chromatin with scant cytoplasm, and nuclear molding, with extensive necrosis and tons of mitoses, and the Ki67 is almost 100%. Another entity for a poorly differentiated neuroendocrine carcinoma is large cell neuroendocrine carcinoma. So the morphology, as the name suggests, you're going to have large, round nuclei with prominent nucleoli and moderate amounts of cytoplasm, with sheet-like to nested growth, and Ki67 is often in the 60 to 80% range. All right, moving on from the well-differentiated and poorly differentiated to mixed neuroendocrine, non-neuroendocrine neoplasms, or menins. So in entities like this is a neuroendocrine tumor or carcinoma with a non-neuroendocrine component. Both have to be more than 30% of the tumor, and it can be an adenocarcinoma or squamous cell carcinoma mixed in with the neuroendocrine, and it's presumed to be clonally related. So a non-neuroendocrine carcinoma dedifferentiates or transdifferentiates to a neuroendocrine carcinoma. So pretty interesting molecular there. So here's an image of a menin, and you have this adenocarcinoma or glandular component, and you also have these small cell neuroendocrine carcinoma component. So this is together would be a menin, a mixed neuroendocrine, non-neuroendocrine neoplasm. Pretty cool. So some common sites. Most neuroendocrine tumors are well differentiated, and neuroendocrine tumors are overall relatively rare. So in the GI tract, they're often polypoid and centered in the submucosa or muscle with intact overlying mucosa. The most common site is the small intestine, often in the ileum, and they tend to present later with advanced disease, either liver metastases or large lymph node metastases at the root of the mesentery. You can also get neuroendocrine tumors in the appendix, often small and incidental. You can get them in the rectum, the stomach, 3 distinct settings or types, and we can look at the stomach tumor guide video that we have to reference those specific entities. And then pancreas is another indication, or another location rather, that you can get neuroendocrine tumors. They arise in the pancreatic parenchyma from the islets and grow into the peripancreatic fat, or less commonly into the pancreatic duct. So the site of origin, you can have neuroendocrine tumor metastasis with an unknown primary. We can do a panel of stains to try to locate the primary. Also, the clinician can do a DOTA or PET scan. So site of origin, if it's CDX2 positive, is likely small intestine. TTF1 would indicate lung. IL1 would be more likely pancreas or rectum, and SATB2 would indicate rectum. So a quick little guide on grading neuroendocrine tumors. This is important to know. So again, we don't grade the poorly differentiated, but for well differentiated neuroendocrine tumors, a grade 1 is going to be less than 3% Ki67 proliferation index and less than 2 mitoses per 10 high-powered fields. Grade 2 is 3 to 20% Ki67 proliferation index and 2 to 20 mitoses per 10 high-powered fields. Grade 3, well-differentiated neuroendocrine tumor, is greater than 20% Ki67 and greater than 20 mitoses per 10 high-powered fields. And then poorly differentiated for small cell and large cell type, you're going to have greater than 20% Ki67 and greater than 20 mites per 10 high-powered fields. So the Ki67 proliferation index is based on evaluation of 500 or more cells in a hotspot, and the mitotic count is based on evaluating 50 high-powered fields but reported per 10 high-powered fields. So some noteworthy variants to be aware of are cystic. So although most neuroendocrine tumors are solid, some, particularly in the pancreas, can undergo central cystic degeneration. You can have pleomorphic nuclei or endocrine atypia seen in endocrine organs, and this can be seen in well-differentiated neuroendocrine tumors. And these changes appear to be degenerative and are not associated with a higher Ki67, and they have no prognostic importance. Another variant is oncocytic. So this is when you have abundant granular oncocytic cytoplasm with eccentric nuclei appearing rhabdoid, and you can have pleomorphic nuclei as well. For a somatostatinoma, this is often ampullary with a glandular appearance and pseumomatous calcifications, and it can be mistaken for an adenocarcinoma. You can also have a clear cytoplasm variant. This is associated with von Hippel-Lindau. You can have a lipid-rich variant with lots of small lipid vacuoles. And you can also have an adenoma carcinoid variant, which is rare, but small neuroendocrine clusters are found incidentally next to an adenoma in a polypectomy. The neuroendocrine proliferation is typically small and is possibly reactive to the tumor milieu. Moving on, so some tumor syndromes. Be sure to check out our GI tumor syndromes video that I just recorded, but we'll go over a little bit here, the ones associated with neuroendocrine tumors. So if it's functioning, that means it's hormone secreting and can have a characteristic syndrome. So functioning tumors are often pancreatic and discovered sooner due to the symptoms that they cause from the hormone production. So non-functioning tumors are often discovered later with metastases or incidentally, which makes sense because if you're pumping out more hormones, that's going to cause other symptoms and other issues throughout the body. So those symptoms will pop up sooner and you'll likely find the tumor earlier, which is good. So for an insulinoma, this is usually small and they present early with hypoglycemia due to that overproduction of insulin. Gastronoma has an association with Zollinger-Ellison syndrome, leading to acid hypersecretion, extensive peptic ulcers associated with MEN1, and most commonly tumor is in the proximal duodenum. For a VIPoma, you're going to have watery diarrhea with hypokalemia and achlorhydria. A glucagonoma, you have this necrolytic migratory erythema, as well as diabetes and stomatitis. For somatostatin, that's going to lead to diabetes, cholelithiasis, diarrhea, and you can have glandular growth and psammoma bodies. For carcinoid syndrome, you have serotonin and kallikrein secretion, leads to flushing, diarrhea, bronchoconstriction, and there's usually only if there's liver metastases with an elevated serum 5-HT and or urine 5-HIAA. So some family syndromes to be aware of is MEN1. So the majority develop neuroendocrine tumors. Pancreas is more often than the stomach or the duodenum. And there's often multifocal proliferation of islets with microadenomas less than 0.5 centimeters and they're non-functional, and well-differentiated neuroendocrine tumors greater than 0.5 centimeters or functional. And also you can have a pituitary adenoma in MEN1, parathyroid hyperplasia, and bronchial and thymic neuroendocrine tumors. For neurofibromatosis type 1, you have an increased risk of well-differentiated neuroendocrine tumors, in addition to lots of tumors like neurofibromas, MPNSTs, GISTs, etc., and particularly ampullary somatostatinomas. For von Hippel-Lindau, you can have well-differentiated neuroendocrine tumors with clear cells. Also, you can get hemangioblastomas, clear cell renal cell carcinoma, and adrenal tumors. And then tuberous sclerosis, you want to think of pancreatic insulin and somatostatin producing neuroendocrine tumors, and also angiomyolipomas and other hamartomas. So that's it, just a quick whirlwind tour through neuroendocrine tumor land. And I hope you enjoyed and appreciate your support for the channel and hope you have a good day. Thanks.